Good afternoon, everybody. Thanks for joining us for today's Complex Pediatrics Echo Clinic. Thanks for being here. We'll start off with some quick introductions of everybody that we've got here in the room, and then we'll go out to all of you and have you introduce yourselves. And then we'll open it up. We do have one case to discuss today from Yolanda submitted that for us. So we'll talk about that, and then we'll get to the didactic presentation for the day. So I'm Troy Jorgensen. I'm the program manager here for Project Echo Nevada. I handle most of the day-to-day operations. If you have any questions about Echo, run into any technical issues, I'm the person to reach out to. So you can just contact me anytime. So go on the table here.
Amy Lansing. I'm a licensed clinical psychologist whose expertise is focused on pediatric chronic disease management. And I'm also a professor at UNR and do teaching and research.
I'm Kathy Eckert. I'm a pediatric endocrinologist and director of the Complex Pediatric Project Echo.
Hi, I am Sneha Sharma. I am the program coordinator for Project Echo Nevada.
All right. So we'll go out to all of you joining us today. Caroline, could you start us off?
Okay, I'm unmuted. Hi, I'm Caroline Cummings. I'm a doctoral candidate in the clinical psychology program, and Amy's my advisor.
Great, glad to have you join us today. Thank you. Tori is next.
Yeah, so I'm the same as Caroline. So I'm a first year actually in the clinical psychology program with Amy as my mentor as well.
Great, good to have you today. Lily. Oh, go ahead, Lily.
Hello, my name is Lily Davalos. I am a trainee in the LEND program.
Excellent. Good to have you join us today, Lily. Thank you. Austin is next.
Hey, I'm Austin. I'm a med student currently on my pediatrics rotation.
Thanks. Good to have you. Tyler.
Tyler, I think it's working. I'm Tyler, third year medical student on my pediatric rotation. I'm out here in Minden.
Great, thanks for joining us, Tyler. Connor?
Hi, I'm Connor. I'm also a third year medical student on my pediatrics rotation.
Thank you. Matt? Matt Malone, yeah, there you go.
Okay, good. All right, my name is Matt. I'm a third year medical student, and I'm at the hospital right now with everybody else.
All right, that's why we're getting some weird feedback. Yolanda?
Hey, I'm Yolanda. I'm a registered dietitian and then also a certified diabetes care and education specialist. It's my new title. Oh, renowned Peds endocrinology.
Thanks, Yolanda. So we're looking forward to hearing your case in a minute here. Catalina, it looks like you haven't joined the audio yet, so just make sure you click the little blue button that says join the audio today. Lisa?
Hi, Lisa Cox, registered nurse, Washoe County School District.
Wonderful. Good to have you today, Lisa. Thanks for being here. Laura? Just a second here, Laura, while we unmute you.
Hey guys, are you there?
Yep.
Laura, third year medical student on pediatrics.
Great, good to have you. Thanks. Jonathan?
Hi, I'm Jonathan, third year medical student on my Peds rotation.
Thanks, Jonathan. Taylor?
So, hi, I'm Taylor. I'm a third year medical student on my pediatrics rotation.
Excellent. Thanks, Taylor. Dr. Bayan? Dr. Bayan, are you there today? Maybe no audio for him. So Dr. Bayan is a physician in Ely, Nevada. And then last is Cody Harry. Cody, it looks like we have audio control for you, but maybe you don't have a microphone. So I will send you a message through the chat if you just let us know who you are and where you work. So thanks, everybody. Thanks for doing introductions. Again, welcome to our Complex Pediatrics Echo Clinic for today. So if you're not that familiar with ECHO, what we do is we put together teams of subject matter experts, like we have here in the room today, and they put on monthly sessions and deliver didactic presentations on set topics, and then they're here to support you with any challenging patient cases that you have. So they're here to consult, answer your questions. Okay, we'll move on. We'll get going here with the didactic for today. But throughout the presentation, if you have questions or comments, feel free to unmute yourselves or write in through the chat box, please. So just a quick disclaimer that we do record all of these sessions. We do edit out any of the case discussion portion and just keep it strictly to this didactic. But if you don't want to be on video, let us know and we can edit you out. And then just a reminder, Yolanda did a great job, but if you do present a case, just know protected health information, since we're in a group setting, we don't want to make any HIPAA violations here.
Okay. So my goal today, this is the third in a 3-part series that I know not everyone was here for parts 1 and 2, but so in January we talked about kind of an intro to type 1 diabetes. Then in February we talked about really all of the digital interventions and tools that we have now for managing this disease. So I'm the third part in this. I'm going to focus less on that background information. And so if I'm going through this, you feel like you're missing that background information, those videos, I think, if they aren't available now, will be available eventually, so you can use them to fill those gaps in. My goal today is to talk through pediatric diabetes from a mental health perspective using the SBIRT frame that is often used in addiction. So thinking about screening, referral, and brief intervention. With 30 minutes, I'm not going to be able to get through all the slides that are in this slide deck. And so what I may do at times is kind of hop through a few slides because I want to make sure I hit each thing, the screening, referral, and brief intervention. And then you should be able to probably access the full slide deck, I think, online. And so it will have some of those other pieces there to touch on. Please feel free to interrupt with questions right into the chat box and let me know. I'm happy to stop and dig in on something. I have no conflicts of interest. I'm not sure if there's other things in this disclosure that were needed.
No, that's fine.
Okay. So I talked through the learning objectives already. I shouldn't have these slides too. So the follow-up from the story of the last 2 months, the message that we've repeatedly heard is that management for pediatric diabetes is excessively demanding. It's expensive, it's complex, you do not get a break from it. We focus a lot on behavior. It's the foundation of diabetes care, but it's not the only influence on blood glucose levels. And both patients, pediatric patients and their parents, often feel out of control about, feel like they can't control their blood glucose levels and then hold themselves entirely responsible. They're having arguments about diabetes that are exhausting. The worries and fears can be all consuming. And so even though we have made so many advances in the technologies available to treat this disease, it's still as exhausting as it was before for our families. And I think it's important to note when we talk about all those wonderful technologies that we have, insulin pumps, CGMs, some closed loop hybrid systems to link those things together, most of our most impaired patients, just like the kiddo we were talking about earlier, they do not have access to these tools. They can't get on insulin pumps until they're checking more regularly. Financially, they're unable to access all of these things. And so oftentimes for our families who are struggling the most, they have access to the least in terms of those technological innovations. When you're facing up against something that is this demanding, it's going to take a toll. Even the most psychologically healthy, financially healthy family is going to express worries about the future, feeling out of control. They may move from that state of distress to experiencing burnout, and beyond burnout burden, that they're exhausted. They're exhausted at so many levels. And when you have a disease this demanding and is taking a toll across time, it can start to get really hard to parse apart emotional distress and the different levels of it. And then when that disease is diabetes, it gets even trickier because some of the distress that happens and leads to poor adherence actually also produces symptoms that overlap with some of these. So today, what I want you to think about is that, we can think of this as a continuum of emotional distress, that the majority of our families are going to report either persistently or at some time in their experience of diabetes, significant distress. That there's the burdens of daily care, stresses and worries, feeling overwhelmed. This state of diabetes distress is twice as common as any major depressive disorder, yet it can present in clinic the exact same. Beyond distress, families who are experiencing even more distress will report symptoms of burnout. So that being chronically overextended in terms of this burden, they're at the point of giving up on diabetes care. Beyond burnout, people will start experiencing depressive symptoms. It may not reach the diagnostic criterion level for a true major depressive episode. And the content of those depressive symptoms may or may not be related to diabetes. It could also be related to other stresses. And then beyond that, you have a major depressive episode that meets DSM criteria. Again, could be related to diabetes, may not be related to diabetes content, but it would be at the most extreme end of this continuum of emotional distress. And the challenge that we have in pediatric diabetes is how do we differentiate these? So diabetes distress is a cluster of symptoms that do not meet criteria for major depressive episode, but reflect negative feelings surrounding diabetes care. And when we look at kind of the sources that people report for diabetes distress, it includes just the demands and tolls of daily management. For many families, they report fear of hypoglycemia being a significant source of distress, especially for parents in particular. Anxiety about high blood glucose levels and resulting complications. Pediatric diabetes contributes to a lot of family conflict. There is stigma, shame, and judgment. Oftentimes, we have really unrealistic expectations for what we can get for time and range for our blood glucose and for our everyday behaviors. We have to give ourselves a little bit of grace and willingness to accept a lack of perfection. There's huge financial strain, right? We need to get the cost of insulin down. We need to make it so that diabetes devices are not only widely available to those with the best insurance and the best health care or the ability to pay out of pocket. And a lot of families and kids may experience isolation, especially as they're adjusting to this disease. That state of diabetes distress is much more prevalent than major depressive episodes. We have good data in adults, but we don't have the best data for this in youth and parents. But anecdotally, a lot of what comes into our outpatient pediatric psychology clinics with a referral message of, we think this is a teen with type 1 diabetes who's depressed, is actually does not meet criteria for major depressive episode and really is diabetes distress. Diabetes distress still is an important thing that we have to address. It is significantly and independent of major depressive disorders associated with glycemic control and with adherence behaviors. And so these are both serious, treatable, and worthy of clinical concern. But I think it's very helpful that we keep this in mind when we're screening and referring to treatment, because if you have a community healthcare provider you're referring to for mental health, they may not be able to differentiate this themselves. They may possibly, if you refer for major depressive disorder, they may do an assessment, say no, they don't meet criteria, and then discharge them from treatment because they are thinking about their traditional treatment model, both in billing and in assessment and treatment. And so the more that we can convey this notion of diabetes distress in our referrals, as that even if there's not major depressive episode, that this diabetes distress is clinically serious, important, and treatable using similar methods, we want to be making that case. I think someone just popped in with a question.
Yeah, there's a question from Dr. Bayan. Is there ICD-10 for diabetes distress?
That is a great question. I don't think so, but I could absolutely be wrong. I'm happy to look in the ICD-10 and let folks know after the fact or shoot a message out from Troy, but last I saw, no. There is nothing in there. And the DSM has actually made it more complex. There used to be a good code for medical disorder affected by psychiatric symptoms in DSM-4. The code was 316, and they modified that in DSM-5, and so it's a little bit trickier, but it still can be used in DSM-5. But they do need to use a different diagnosis there. But I actually don't know if there's something similar in ICD-10. I think there should be, but I don't bill Medicaid right now, and so I'm honestly not up to date on ICD-10. So we care about both of these things, and then the biggest hurdle really is that these symptoms, irritability, sadness and anxiety, cognitive impairments, fatigue, weight loss, sleep problems, changes in appetite and thirst. These are actually, excluding suicidal ideation, these are all symptoms of major depressive episodes. They are also the symptoms of chronically high blood glucose levels. We may see all of these things present. And so one of the biggest challenges when you're screening for these things is trying to parse apart what is the result of chronically poorly controlled type 1 diabetes and which of it is depression. And quite frankly, you probably won't know until you until it's treated, right? That if you go in and start, and they could be feeding on each other, right? To the extent that you're at risk for major depressive episode and you're mismanaging diabetes is driving all these symptoms, you're likely to get more depressed, right? And experience more depression. Or vice versa. You may have a major depressive episode that leads to poor diabetes management and then worsens all the symptoms of a depressive state. What I want to encourage is not that you magically can differentiate these in clinic, but more to make the point that keeping both in mind, that what looks like depression may not be full major depressive episode. And so when we refer, we want to make clear to the provider, I don't just want you to treat depression. You may be treating broader distress related to diabetes, and we won't know until later. They can slap on a provisional major depressive episode diagnosis until they figure it out later in treatment, but we want to make sure families are getting into treatment and not getting turned away because they don't meet criteria for a mood disorder. So I'm going to skip ahead here because I'm being conscientious of the time, and I want to get into a little bit of information about how frequent we think major depressive episodes are in teens with diabetes, and then how to screen. So about 25% of teens with diabetes report elevated depression symptoms. This is not a major depressive episode, just depressive symptoms. And a similar amount, about 23% of teens with diabetes report subclinical levels of depression. And so this is probably reflective of the ways in which our depression screeners also are picking up on diabetes burnout. And so this suggests to us that we expect perhaps 50% of our teens with type 1 diabetes are experiencing diabetes distress. And that it may be even larger than that if you look across their whole, that's just a point prevalence, right? So if we think across the whole disease, the majority of them are likely experiencing this. But when you see a kiddo presenting with those symptoms, there's a high likelihood that you're seeing some diabetes distress in this. I brought up that we think this is cyclical already, that we think these things, that diabetes is driving some of the depression, and then that turns over.
Are those symptoms, either of those last two categories, are those correlated with diabetes, with blood sugar control?
Yes, absolutely.
Yeah,
absolutely.
Yeah, and hospitalization?
In terms of DKAs, yes. Yeah. So depressive symptomatology, even if they don't meet diagnosis, is associated with higher A1Cs and more frequent emergency room visits and hospitalizations for DKA, and it's also associated with hypoglycemic events. So both directions are associated here. And so we expect that pretty much this tells us, and then another percent of these kiddos have actual major depressive episodes, right? And so we expect that the majority of teens coming into any Peds endo clinic, nurse's office, primary care clinic are likely going to report some symptoms of depression. It should be the basic expectation. I hate forgetting about family members, but I'll mention them briefly, but I want to move on to our screening tools. But right now I've just been focusing on the kids, parents of these kids, especially mothers of younger kids with type 1 diabetes, also experience significant depressive symptoms, distress, and burnout. And then their experiences feed into their youth experiences. And so sometimes we can't only be thinking about treating depression in the teen or the child. We're thinking about, we have to actually address it within the family members as well if we really want to move things. And that's tricky. You aren't typically seeing the parent. They are not the person you're treating. And so, you know, but we also need to think about how that's affecting the health of the teen as well. So how to go about screening. The American Diabetes Association current standards of care have recommended that all clinics be screening for depression and eating disorders at a minimum, starting by like age 12 about. But there are multiple pediatric endocrinology clinics that have put forth larger screening protocols that they're attempting to lay out. One of the biggest issues with screening, and I'm going to touch on it, is what do you do with all of this information you're getting, right? Especially in a healthcare system like ours where we don't have a lot of mental health resources. Let's start just with screening. So the recommended depression screening tools are the Patient Health Questionnaire 2-item and 9-item. There are adolescent versions of those that are validated. You can find them free online. Usually you can use the 2-item first. And if they screen positive on either item 1 or 2, the PHQ-2, then you ask them to continue on and fill out the PHQ-9. The 9th item on the PHQ asks about suicidal ideation. I know there are clinics who only use the PHQ-8 and ignore the suicidal ideation question because they don't feel prepared to assess it. I'm going to talk more about suicidal ideation and suicide screening on I think the next slide, either 1 or 2 slides down, because there are good tools we can implement for this, and you are not harming people when you ask them whether or not they think about suicide. There is a great diabetes distress measure called the PAID. There is a teen and parent report version. The 2 links I've included in the slides that will go up online are to a copy of the questionnaire and then a new article, I think it's from 2018, sometime 2017, 2018, that released clinical cutoffs for the PAID. So it's a well-validated measure that has clinical cutoffs to tell you about a national norm of how distressed a kiddo is. And this can be really helpful if you're assessing both depression and diabetes distress. If they aren't screening positive on depression, they may likely screen positive on diabetes distress. And so I highly encourage considering using both when you're thinking about screening.
So I just found the link for that PHQ-9 for adolescents. I sent that out through the chat box.
Perfect. So when possible, consider using both things. And that can help you with a referral out to a community mental health provider. It can also help that the community mental health provider would know then how do they monitor improvements in symptoms. They can monitor that through the PAID. They can know if they're getting better and feeling better. ADA has now recommended all teens with type 1 diabetes be screened for eating disorders by age 10 to 12. There is a well-validated in teens eating disorder assessment. I've included the link here. And then the other thing that I want to draw attention to are the NIMH tools for pediatric suicide assessment. The ASQ is a set of 4 screening questions that only takes about 20 seconds to administer. They've administered this in as young as 10-year-olds. These 4 questions, if you screen positive on at least one, it's identified 97% of kiddos at risk for suicide. The NIMH toolkit, what I love about it is that it doesn't only have just the measure, it has resources for parents. So it has resources for how to explain the screening. It has resources for what to do if someone screens positive. And so it's a fabulous toolkit that is publicly available. They're very clear. The link I've included here, they have one for inpatient, they have a medical outpatient, and then they note that schools can use this too. A school nurse's office still counts as a medical outpatient office. And so this wouldn't be, the DEPS is just for diabetes related eating disorders, but these suicide toolkits are anything. They're not diabetes specific. You can you can ask these questions, you can integrate these into clinics more broadly for kids. And it's a great resource that you can feel comfortable doing this in a clinic that doesn't provide mental health services. This link is to a comprehensive screening and intervention paper that talks about the Lurie Clinic in Chicago. I think also it's probably Jocelyn's clinic in Boston came together and wrote this paper about how they're approaching pediatric screening. They also measure quality of life, family conflict, family stress as well. But at a minimum, getting depression and distress, eating disorders, and suicide addressed would be the starting point. Once you have this, what do you do with it? right? What do you do with this information? And probably as, if not more important than the screening process, is how you approach a referral. When you are approaching a referral to a family who has a chronic disease like type 1 diabetes, I recommend taking a biopsychosocial approach, not saying you have a mental health issue, you go talk to the mental health people, because we don't do that here, but to approach it using a conceptualization of the problem symptom, let's say persistently high blood glucose, persistently high diabetes distress, right? But usually the problem symptom you're quantifying is biological, something that you're measuring in clinic, that you can walk through all of the types of things that might impact those symptoms, right? There are physiological things like medication regimens, puberty, changes in insulin resistance, weight, all of those pieces. Working across this diagram, there are behavioral things like sleep, activity level, diet, and exercise. There are functional things like, are you going to school? Are you engaged in extracurricular activities? Engagement in extracurricular activities predicts improved glycemic control because you get more monitoring and supervision, right? We can also consider the social environment, what's going on in the family life, school, social support, peers, and the psychological domain. So stress, psych history, emotional responses. And that if our goal is to reduce this problem symptom as much as possible, we want to be targeting this at every angle we can. And the care you may provide in your clinic focuses more on the physiological, but you'd love to connect them with someone who can help them with, sleep and exercise and activities, engagement in school, managing peers, diabetes distress they're experiencing. You don't have to say, I think you're depressed, you need to go talk to a psychologist or a psychiatrist. You can present this larger picture to say, we are going to use a whole child approach to care. We are going to look at all of the pieces of the puzzle, and we're going to make recommendations for you to talk to all different providers to help support this holistic view of treatment. And to the extent that families hear that message, I'm not saying it always works 100% of the time, but to the extent that our messaging is not just, oh, you screened positive on a depression measure, you need mental health services, to the extent that we can provide a really holistic rationale for why as a physician or a nurse or a medical care provider, I'm asking you to seek additional care, to the extent that we don't otherize it and say that's the psych stuff and I'm not there, we are going to be more likely to get families to show up to the referral source, right? So often, if you look at the SBIRT model in addiction, the majority of referrals go unanswered. They make referrals to treatment once a teen screens positive for substance misuse or abuse, and families never show up because there's stigma. They're embarrassed. It's a whole nother visit. They think that if they get support from mental health services, they're going to lose the physiological rationale, right? We see this more in chronic pain type kiddos, but even in type 1 diabetes, right? They may be really sold that this is a medicine problem, right? That something's wrong with my insulin, something's wrong with my dose, this isn't a psych problem. And your goal here is to frame it as they're all both, right? Every child that comes into this clinic, we are going to be asking questions about all of these things because we want to make sure that if each of these things can get a 10% decrease in blood glucose levels, then let's do all of those things. Let's work on each of them. And so that helps reduce bias and stigma, and it helps increase the likelihood of a referral happening. The other thing that's really critical about the referral I've been alluding to is a lot of our teens and kids with type 1 diabetes show up to a community mental health provider who has no clue what type 1 diabetes is. They assume it's type 2 and that they just need to eat and exercise and that it doesn't really have a place in their clinic. They don't understand fear of hypoglycemia. They don't understand how all the tech works. They don't understand really anything about the disease because they haven't been exposed to it. And so they treat the case like any other case that comes in. Do you have a psych diagnosis that I can treat for? And oftentimes these kids don't pop up in that. And so to the extent that your referral can make this clear to the mental health provider, but not just your referral, that the parents can walk into that mental health care provider and say, here's why we need treatment. That, we're working on this from the med side, but we have this persistently high blood glucose control that's actually related to sleep and diet, that's related to success at school, that's related to symptoms of distress or anxiety or depression. They don't need to use the anxiety and depression word if they're uncomfortable with it. They can call it distress. That's okay by me. But to the extent that a parent can walk into a mental health care provider and offer that, the more likely it will be that they will receive the appropriate services. And so the last piece of this puzzle, this is everything I was just saying, but in words. The last piece of this puzzle, I'm going to jump forward in some slides here. I'm trying to think of how best to use these last 6 minutes because there's a lot more in the puzzle. So there's 2 problems that remain next. Can you do a brief intervention in your clinic? Is there something small you can do in the clinic that's useful? And then what should a mental health care provider be doing in therapy to support a teen or a child or family with diabetes? Knowing both is helpful, because if a family comes back to you and says they didn't do anything, it wasn't helpful, ask them what the therapist did. And if the therapist wasn't doing some of the things that are on these slides, then they weren't getting the right evidence-based treatments. And so I think it's important that everyone knows what the evidence base is, because oftentimes families are going to come back and say it didn't help. And this happens even within psychology. I get families that come to me and say, we already got therapy for anxiety, it didn't work. And I say, tell me what you did. Oh, well, you guys didn't get the evidence-based treatment for anxiety disorders in kids. We can help. Like, it's going to look different with us. And so the same plays out here. I'm not going to be able, in the remaining time I have, to explain all of these pieces, what I want to highlight are the 4 interventions where we have a strong evidence base. One of them is in behavioral family systems therapy. There is a publicly available 14-session treatment model for behavioral family systems therapy for teens who have type 1 diabetes that has been shown to be effective in reducing family conflict, improving communication skills, and has some data to support improving glycemic control. Margaret Gray at Yale tested a coping skills training program that trains adaptive coping skills that has great effects in evidence base. It can be done as group therapy or as an individual. It's also a publicly available treatment. There's a family teamwork and cooperative problem solving intervention. Any flavor of it is helpful. Collaborative problem solving from Harvard is called Think Kids. Any basic family teamwork CBT model will be effective. And then also quality of life monitoring has support. So the checking in around quality of life, questions in improving patient-provider communication. These are the things we want to be hearing that they're doing. And then beyond these interventions for type 1 diabetes, if you know a child has a diagnosis of major depressive episode, they should be getting CBT. That's what, if you know that they have a PTSD diagnosis, they should be getting trauma-focused CBT. It is the gold standard evidence-based treatment for PTSD in kids. And so to the extent that you can check back with a family who flops out of therapy or who is showing up to therapy and not improving, checking on what interventions they're actually receiving with that therapist. Because it's possible that they're just getting supportive care from that therapist. And so that is a challenge that we run into often. This last section of slides is where I talk about some of the things that you can do briefly in your clinic. So it's the end of expert. After referral, there's brief intervention. In the addiction expert model, they focus on motivational interviewing strategies, and I raised some of those here. But a couple of points that I want to make are that diabetes is not DIY. You need family, you need friends. And so we always want to be thinking about how we can increase social support for teens and their parents. There are in-person supports. We've got community groups here like the Nevada Diabetes Association, the Diabetes Youth Foundation, JDRF. They host camps, they do events. There are also clinic-sponsored events. You can ask the diabetes care team for referrals to those. There are also online support groups that are really robust in the diabetes management world. These are a couple. Diatribe is probably the favorite of this group, but the online social support network is also strong if a family doesn't want to attend groups, getting them looped in. Focus on strengths. I won't dig in more than that. Just to the extent that you can shift the focus and tone of your clinical encounter to strengths, you will find much greater progress in behavior change across time. Praise behaviors, not numbers. When we punish numbers and blame and shame, we get no behavior change. And so focus a lot more on simple behaviors. Catch youth doing well with diabetes management. To the extent, even if the A1C is 12 and they only check 2 times that week, to the extent that you can pick one thing that they did well, notice it, create a positive atmosphere around it, reinforce it, that behavior will be more likely to increase across time. And set realistic goals. When we set huge goals in clinic, you should test, I want you checking your glucose 4 times a day, because that's what we need to get you to do, probably to get you on a pump. Like, great, if they're doing it twice a week, that change is too big. Yes, it's what we want to see, but we're more likely in between visits, or if it's a school nurse and I'm trying to get some small behavior change each week, small changes, focus on a behavior that you think can be accomplished 80% of the days next week. 5 days out of the week, they'll be able to pull it off. And that may be starting with 1 check a day. But start small and set realistic goals, and you're much more likely to see behavior change from your clinic visits. And then also, beyond those behavior change issues, we can think about how we can improve well-being by supporting healthy coping in our brief clinic visits, by supporting parents and providers who are really frustrated with teenagers and just want to boot them out of clinic, to stay involved in diabetes management, and to also help families decrease family conflict. And I've got a couple of strategies that I'm not going to dig in on here in these slides that you're welcome to look at and think about, but maybe I'll come back a different month and can dig in on some of these strategies when we have a little bit more time. The last thing I want to end with is that one of the best things you can do for your clients when you're worried about them is build a strong relationship with them. If you've got a patient in clinic, you aren't sure if the referral is going to work, focus on cultivating empathy and respect for how hard this is, encourage social support building, and work to repair relationships when your trust is lost with a patient. So identify a common goal and return to it frequently. If a parent's getting angry in clinic, then nothing's going to work at that point. Come back to a common goal. We're both here because we want to find the best path forward for your kiddo right now. What is a goal we share? Return to it, and then make very small goals, small plans that move you towards that goal and fit the expectations of both groups. You can stay firm on non-negotiables, but appreciate your frustrations when you do that. And so that's one of the biggest places you can get gain. The stronger relationship you have with your patient, the more likely they are to follow through on a referral. And so this is a big step that we can be taking. I know we're up with time right now, but one thing I want to mention is that I'm happy. I don't have a clinic right now that is seeing patients, but I'm always happy to provide consultation. And if that may be to a mental health provider, I'm happy to train a community mental health provider on what they do when they work with a parent of a young child with diabetes or a teen who has diabetes. And so feel welcome if you're running into this as a school nurse. I'm working with a school nurse at Dunn soon here with a kiddo who has type 1 diabetes there to try and consult with the school nurse on things they could try. And so I'm happy, even if I can't provide direct clinical services to families, to provide consultation as well. Or bring them to this clinic. You can get consultation here.
Yeah, absolutely. All right, so we'll start to wrap up for the day. We'll open it up right now, see if anybody has any questions. Question already from Dr. Bayan. How about adults? They seriously indeed do behave like kids.
I know. I just unless you're a parent, I'm like, get out of here, adults. No, I don't do it. No, I think a lot of the same principles apply. Everything that I laid out in screening, there's an adult version of the PHQ 2 and 9. There's an adult version of a diabetes distress measure that Jeffrey Gonzalez's lab has validated. I forget the acronym for it, but there's an adult version that's validated out there with clinical outcomes. The eating disorder measure is good, validated for adults as well. And then NIMH also has an ASQ kit for suicide evaluation for adults. And so all those tools exist, and then the same things apply. I mean, the referral model, the challenges that adults face in these referrals, and then what you can do in brief intervention. Doesn't matter whether they're 45 or 14, a lot of the same behavior change principles apply. 14-year-olds are just harder because you got to change their parents' behavior too. Do both.
Anything else we can help with before we wrap up today? Alrighty, I think we'll end there. Quick reminder about our next session. So we'll be talking again on April 10th. We'll have a guest presentation from Dr. Stadel. He's a local, I think he's a dermatologist, talking about skin diseases in the school age population. So April 10th for that one. We hope you'll join us then. And then I'll send out the link right now if you need to claim CME or CEU credit. Just submit the evaluation using that link. So thanks so much, everybody. Hope you have a great rest of your day and a good weekend. And we hope to see you next time, April 10th. All right, bye-bye.